I'd like to call upon my first speaker, Dr. Sudha Ganesh. He is the Director of Uveitis and Shankar Netralaya of 30 years or more experience. He'll be talking on a very important topic, TB or not TB, a perennial question. Dr. Sudha, please.
Very good morning to everyone. I wish to thank Dr. JB for including me in this session. Now, TB or not TB, that's the perennial question that we all have. Is it TB uveitis or not? Why do we have this controversy? The reason is because there's an absence of a gold standard single diagnostic test for TB. Most of the clinical phenotypes are overlapping. There is a limitation of the immunological testing, and it's not always associated with systemic involvement. And as you know, TB uveitis is a paucibacillary infection. So the global prevalence of ocular tuberculosis is only 4%, but in endemic regions it's between 22 to 48%. Endemic countries like India, Indonesia, Philippines contribute to more than 50% of the global burden, but the incidence is rising with global migration even in the non-endemic countries. So before we go into what TB is and how do I diagnose it, we need to know the immunopathophysiology of TB uveitis. It can be a direct MTB infection of the intraocular tissues where the MTB may be demonstrated within the eye. So once you have the hematogenous dissemination of the MTB, there is a breakdown of the blood retinal barrier, either the inner or the outer, and this is followed by the RPE cells which orchestrate the innate and the adaptive immune responses along with the immunoregulatory function. And following this, there's an elevation of the cytokines, and most often this kind of an inflammation results in formation of granulomas either in the anterior or the posterior segment of the eye. Another way is the immune-mediated inflammation. Here there is an induction of specific antiretinal immune responses due to the mimicry between the TB antigen and the retinal antigen, and most of the clinical phenotypes of ocular tuberculosis are a combination of both these mechanisms. A paradoxical reaction is a clinical worsening or progression of the active lesion while on ATT. Having understood the immunopathophysiology of TB uveitis, now how do I decode a case of TB uveitis? The first step is recognition of the clinical phenotype of ocular TB, suspect TB uveitis. Second step, understand the immunopathophysiology of TB uveitis. Third step, look for supportive evidence with investigations. After this, you refer to the readily available Sun and the COT guides and the criteria for TB uveitis. So the first step, how do you recognize the clinical phenotypes of ocular TB? These are predictive features suggesting ocular TB, a granulomatous inflammation in the anterior segment in form of granulomatous anterior uveitis, the Busakas or the Keppes nodules. At times you may even have a scleral nodule. The others are the occlusive vasculitis, a serpiginous like choroiditis or a tubercle. Other phenotypes being intermediate uveitis with chronic recurrent inflammation and snowbanking along the inferior pars plana, and small tuberculomas that present in the posterior pole typically can be picked up by the new OCT features that show a typical granuloma with a contact sign and most often the outer retina being involved. In both these pictures you can see one is a small tubercle granuloma and the other one is a peripapillary granuloma which resolve with treatment. The other phenotypes are the multifocal choroiditis, the TB subretinal abscess and the TB neuritis. Tuberculous endophthalmitis is a very rare and sight-threatening inflammation and usually presents with dense vitritis with exudates, retinal or choroidal masses, and often mimics intraocular tumors and other infectious etiologies. So once you've done all this, you've got the ocular phenotype, you know the immune response, now you look for the supportive evidence in form of microbiological or radiological diagnosis. Look for the positive IGRA or the TST and the imaging features. Exclude entities like syphilis and sarcoidosis. There you have the diagnosis of TB uveitis. But if you don't have a proper phenotype and if you don't have the supportive evidence, then it may be tricky to start the treatment for TB. And you may have to look out for the cytokine profile or the molecular mediators of inflammation. So these are the steps, and you connect the dots: history or suggestive of exposure to TB, identify clinical phenotypes, use ocular diagnostic tools like OCT, FFA, ICG, UBM and USG. Look out for the aqueous vitreous tissue biopsy analysis for TB. Support it with systemic workup, and still in the end in most situations the diagnosis remains presumed because you need to diagnose based only on the compatible clinical phenotypes. Just a few words about the vitrectomy and the PCR studies. Most often PCR and RT-PCR use a single target like the IS6110 or the MPV64, and IS6110 is absent in 10 to 40% of the TB samples. And the multi-targeted PCR, which looks for the third target, the protein B, has an enhanced sensitivity and specificity. And tests like the Gene Expert, MTB, RIFSA and the Line Probe assay can provide extremely useful information on drug resistance and explain recurrences despite ATT. Now coming to the clinical based case dilemmas, you will see how each one of these cases were TB or not TB. This was a 44-year-old male who presented with difficulty of vision in both eyes for the last 1 month. He was diagnosed as an occlusive TB vasculitis by his local doctor in both eyes and had 1 dose of anti-VEGF. He was on ATT and oral steroids when he presented to us. His investigations, quantiferon was positive, MAN2 was positive. There were non-calcific nodes on the lung on HRCT. If you look at the clinical picture, you can look at an occlusive vasculitis. FFA shows delayed filling with staining of the vessels. But when we did a screening, we found the TPHA positive with very high titers, and he was seen by an ID specialist. The ATT was stopped, steroids were discontinued or tapered, and he was given benzathine penicillin. This serves as a reminder that syphilis could be a great masquerader. The next case was a patient, 24-year-old, who had a poor vision in the right eye for 2 weeks. The past history was she had an MTB positive, she had a tuberculous lesion on the lung, and she had ATT. She had a granulomatous uveitis. The local doctor had treated her and had also operated her for phaco-IOL and a YAC capsulotomy done. But she came to us with a vision of 1/60 in the right eye. And you can see that there was a granulomatous inflammation in the right eye, and the vitreous showed a dense haze with a hyperemic disc and a thick vitreous membranes in the inferior vitreous cavity. The working diagnosis that we had was that of a granulomatous panuveitis. Now what was in our mind? Was it an endophthalmitis following cataract surgery? Was it an ocular TB endoff after ATT? How does that happen? Is it a multi-drug resistant tuberculosis, or is it a paradoxical reaction after complete ATT? So we decided to do the AC-TAP PCR studies and do a UBM to locate the IOL. We re-investigated her and we just found the QTB positive. So what did we find on UBM? We found a large mass, ciliary body mass on UBM. And the AC-TAP revealed the real-time PCR of the aqueous sample that detected more than 1,000 copies of the RT-PCR and was negative for all other infections. We diagnosed probably that she had a TB endophthalmitis. She underwent a vitrectomy. Vitreous aspirate again was positive for the IS611 genome of MTB. So we had to put her on a second-line ATT with moxiflox and oral steroids. And at the end of 12 months, she did have an improvement of vision. Now this was the 86-year-old who presented with loss of vision in the only eye in the left eye. Vision was PLPR inaccurate in the other eye. So her past history was that she had a QTB positive, was diagnosed by her local doctor as a choroidal granuloma in the left eye. She was on ATT, periocular steroids with no improvement, deranged LFT, and her doctor had also given her IVMP for 5 days. When she presented to us, she had disc hyperemia, subretinal macular lesions, vitreous haze. There was evidence of subretinal abscesses with satellite lesions. We made a diagnosis of a possible endogenous endophthalmitis with a subretinal abscess. We screened her for HIV and CD4 counts. Her CD4 counts were low and her HIV was negative. Her PET CT scan was negative. We did a vitreous biopsy. And what did we find? We find Pseudomonas aeruginosa, which grew. You can see the iridescent colonies of Pseudomonas aeruginosa. She was given intravitreal and systemic antibiotics. She underwent a vitrectomy. Unfortunately, succumbed to systemic sepsis. Now this is the next case. A 30-year-old man had difficulty of vision both eyes. Best corrected visual acuity of 636 both eyes. MAN2, QTB and HRCT were positive. A diagnosis of serpiginous-like choroiditis was made. Was given ATT and steroids. He did resolve with repeated attacks of inflammation. At the end of 4 years, this is how the fundus picture was. So TB, serpiginous-like choroiditis, occurs in highly endemic regions, and this is an MTB-induced hypersensitivity reaction within the choroid or RPE, has significant vitritis, multifocal lesions in the posterior pole. It starts off as discrete, non-contiguous, multifocal plaque-like choroiditis, which becomes contiguous with time. Whereas when you look at idiopathic serpiginous choroiditis, which occurs in the non-endemic regions, it typically begins in the peripapillary region. It spreads centrifugally, bilaterally, and it's asymmetric with minimal or no vitritis, and a misdiagnosis can lead to unnecessary antimicrobial treatments for idiopathic serpiginous choroiditis, which is often treated with steroids or immunosuppressives. This was a child who was presented with vitreous hemorrhage in the right eye and left eye, had a serpiginous-like choroiditis. Investigations, skin test positive, a large hilar lymphadenopathy, and was put on ATT and steroids. But what we found was the choroiditis was progressing with subretinal fluid. And 2 weeks later, the subretinal fluid was increasing. The treating ophthalmologist suspected a steroid-induced CSR, stopped the steroids but continued the ATT. And you can see the child after 3 days of tapering presented with severe orbital pain and proptosis, lid edema, congestion and chemosis. But the FFA had no clue showing you the CSR, so it was definitely not a CSR. We suspected a possible paradoxical reaction. ATT was continued with IVMP and steroid. We did do an MRI and an ultrasound to rule out orbital cellulitis. And this is most probably a paradoxical reaction which occurs due to release of MTB following ATT due to delayed enhanced hypersensitivity reaction, and this has to be differentiated from treatment failure, drug resistance and poor compliance. And this was at the end of 4 months of IVMP, steroids, anti-VEGF and ATT. And this was another case of AMP, which had positive quantiferon and HRCT suggestive of old pulmonary tuberculosis. But if you can see the FFA, ICG and other pictures more suggestive of AMP, this patient could not tolerate an ATT. We had to stop it, but he resolved completely with only steroid therapy. So when we have a patient having a question as to whether it's TB or sarcoid, the CORD study 1 has shown that both the TB posterior uveitis and the sarcoid uveitis report granulomas in 12 to 13% of their cases. Both have very distinct clinical and imaging features that differentiate between the two entities with high predictability in addition to your immunological tests. You can see this was a peripapillary choroidal granuloma, and if you look at the OCT picture, you can see a nice granuloma with the involvement of the outer retina and a typical contact sign, which is unmistakable. So these tuberculomas, tuberculous ones, tends to be solitary. They are intensely yellow, larger, full thickness, lobulated with lot of vascularity and hemorrhage, and the vasculitis associated with tuberculosis is often occlusive. Whereas when you look at the sarcoid granulomas, they are diffuse, they are bilateral, multiple, small, partial thickness, dull yellow, rounded. They are not associated with vascularity and generally don't involve the outer retina. And the vasculitis usually has a lot of skip lesions or candle wax drippings, as they call. This was one of our patients who had a bilateral sarcoid granuloma with extremely elevated ACE levels and hilar lymphadenopathy. You can see the patient had a choroidal CNVM in the left eye. With steroids and anti-VEGF in the left eye, it completely resolved in 3 months. You can see the sarcoid granuloma on the OCT where I've drawn the arrow. So you could use the CORD guidelines for starting off the ATT, look at the clinical phenotype, and then you try to look at the immunological test and the radiology, and then decide on whether you're going to give the patient ATT or not. So in conclusion, intraocular tuberculosis is a complex interplay between the MTB virulence and the host immune response. We need an immunology-guided diagnostic and therapeutic approach. Though the standard for diagnosis is demonstration of MTB in the tissues and the ocular fluids, the CORD study suggests that the positive or negative PCR does not influence the treatment of TB uveitis in the real world scenario. Why? Because of the low sensitivity and lack of standardization. Hence, diagnosis of TB is mostly based on the clinical phenotype and the immunological investigations. We need a very good clinical judgment with integration of the presenting phenotype, contact risk and immunological testing and imaging to help us in enhancing your diagnostic accuracy. These are some of the diagnostic tools in TB. And thank you very much for your patient hearing.
Thank you, Dr. Sudha, for the elegant lecture. And you have nicely demonstrated by the case presentations how TB should be differentiated from non-TB entity. There is a beautiful presentation.